Yes, so I hope I am visible and audible to all of you.
Yes, sir.
All right, then, so it has been a very long time that we have done the sessions. Now, in the today's sessions, let us try to start from the nephrology. So the two topics which we have finished are cardiology and as well as the endocrinology. Right. Yes. So is my screen visible to everyone?
Yes, sir.
All right. So in the today's session, we will be discussing the acute kidney injury. Right. And this acute kidney injury, it is nothing but the renal failure. So first of all, let me just tell you one big sorry for all of you. Yesterday, I think definitely I might have made you kept on waiting, right? I think this is the second time which I have done. I'm extremely sorry, and it was an emergency case which I did not anticipate. I was just leaving the hospital to come to home to take your class, and when I was just leaving the hospital, so there was an emergency where the patient has to be taken for the PTCA. It was an emergency and complicated case, so it took a lot of time for me. It went on until 6:30, wherein I couldn't even reply also to some of the calls where the coordinator was calling, and even Vivek Shresh also called. So I couldn't take your calls. I'm very sorry for the yesterday's event. So, and by saying that, now let us start with the today's discussion of the acute kidney injury and as well as the acute renal failure. Now, okay. So now please tell me, like, how is your cardiology? So, did you revise and did you read? Have you done the questions? And I think in between, some of you have asked me about the questions on hypertension. I think I did not send you the questions on hypertension, right? Regarding the topic of hypertension, I did not send the questions on the Telegram channel. Yeah, yes. So I will send the questions on hypertension. So maybe today or tomorrow I'll be sending you the questions on the topic of hypertension. And today I'll be discussing the acute kidney injury, and even I'll be sending you the questions on the topic of the acute kidney injury as well. Okay. So these two topics questions I'll be sending you on my Telegram channel along with the explanation. I'll be sending you by the end of the night. Okay. But first I'll send you the questions, and then later I'll be sending you the answers with explanation as well. So all of you, please don't give any excuse in doing those questions. All of you try to definitely solve those questions without fail. Okay. Right. Now, whenever we are discussing the kidney injury, we have to take up two important parameters into consideration. What are those two parameters which we need to take into consideration while discussing the kidney injury is one is
Urine, creatinine,
yes,
and
one is your the nitrogenous waste substances, that is the serum creatinine and as well as the urea. So if you take the creatinine and as well as urea, they are the substances which have to be excreted through the kidney. And if the kidney is injured, the creatinine and urea is not excreted. So thereby the levels of nitrogenous waste substances, they are increased. And then what will happen to the second important parameter which tells you about the kidney injury is the urine output. So kidney is a very important organ which helps in maintaining the urine output. Can anyone tell me how much is the normal urine output? Yes. How much is the or what is the normal urine output?
1 ml per kg per hour.
Yeah. So it is 1 to 1.5 ml. Right. It is 1 to 1.5 ml per kg per hour. That is the normal urine output. Now, whenever there is a kidney injury, either you take acute kidney injury or you take the chronic kidney injury. So, what will happen to the urine output? The urine output will be reduced. And to how much extent the kidney, to what extent the urine output will be reduced is very important in case of the kidney injury. The urine output will be reduced to less than 0.5 ml per kg per hour for nearly around 6 hours in case of the acute kidney injury. right? In case of acute kidney injury, the urine output is reduced to less than 0.5 ml per kg per hour for nearly around 6 hours in case of acute kidney injury. Then I said you that there will be increase in serum creatinine and as well as urea, which are nothing but your nitrogenous waste substances, or which are the metabolic waste products of our body. And how many times the serum creatinine has to be elevated? The serum creatinine is being elevated by more than or equal to zero point 0.3 milligrams per deciliter within 48 hours. Okay, so that is what is the increase in serum creatinine in case of acute kidney injury. So how much it is elevated? It is elevated by more than or equal to 0.3 milligrams per deciliter within 48 hours, or right, or it is increase in serum creatinine more than or equal to 1.5 times the baseline, right? More than or equal to 1.5 times the baseline. Okay, so that is another definition, another part of the definition of the acute kidney injury. Now this entire definition, right, this entire definition, who has given this entire definition? This entire definition has been given by the KDIGO guidelines. Okay, this is being given by KDIGO guidelines. Okay, that is the standard guidelines for defining the acute kidney injury, right? Now, next to this, you need to be very much aware of the normal urine output. Already I have said you how much is the normal urine output. That is around 1 to 1.5 ml per kg per hour is the normal urine output. And when the urine output is reduced to less than 0.5 milligrams per deciliter, 0.5 less than 0.5 ml per kg per hour, then we call this as the oliguria, right? We call it as the oliguria. So to call it as oliguria in a 70 kg individual, the urine output will be less than 400 ml per 24 hours. That is what is called oliguria. Just 1 minute, I'm very sorry. Right. So yeah. So when do we call oliguria? We use the word oliguria when the urine output is reduced to less than 400 ml per 24 hours. Then we have another terminology called as the anuria. Now, when do we use this word anuria? We use this word anuria when the urine output is less than 100 ml per 24 hours. That is what is called as the anuria. Now, if we take this definition of anuria in the form of the ml per kg per hour, okay, so it is less than 4 ml per kg per hour. That is what is called as the anuria. Okay, so this is what is the definition of acute kidney injury according to your KDIGO guidelines. Now we have one more guideline which has given the definition of the acute kidney injury, and that is not being followed in a broad way. In a broad way, the criteria that is being followed is according to the KDIGO guidelines. Now, the another important. Sorry.
0.4 ml or 4 ml in anuria.
Yeah, in case of right, yes. In case of anuria, it is less than 4 ml per kg per hour. That is what is called as the anuria. All right. Right. Then. Right. Right. I'm sorry. So this is okay. Yeah. Yes, PB. Is this clear now? Less than 4 ml. Right. So, yes. So, when do we use the word anuria? We use the word anuria when the urine output is less than 100 ml per 24 hours, or when the urine output is less than 4 ml per hour. It is not less than 4 ml per kg per hour. It is less than 4 ml per hour. That is when we use the word anuria. Next, we have another important criteria that is called as the AKIN criteria. Now, what is this AKIN criteria? That is acute kidney injury network criteria. Right? What is AKIN criteria? It is acute kidney injury network criteria. Now, according to this AKIN criteria, what are all there? So it has been the acute renal failure. It is classified into 3 stages. Okay. What are those 3 stages? That is stage 1, 2, and as well as 3. So in this criteria, we take serum creatinine into consideration, and we take the urine output into consideration. So in stage 1, according to the acute kidney injury network criteria, in stage 1, the serum creatinine, it is increased by how many times? 1.5 to 2 folds. And what will happen to urine output? Urine output is reduced to less than 0.5 ml per kg per hour for nearly around 6 hours. Okay, for more than 6 hours. Whereas in case of stage 2, acute kidney injury, there will be increase in the serum creatinine. How many times it is increased? It is increased to almost 2 to 3 folds. And the urine output will be reduced. How much it will be reduced? Less than 0.5 ml per kg per hour for more than 12 hours. Right? For more than 12 hours. Whereas in stage 3, there will be increase in serum creatinine, but how many folds? More than 3 folds, there will be increase in the serum creatinine, and urine output will be less than 0.3 ml per kg per hour for nearly around 24 hours. So this is the classification of the acute kidney injury by acute kidney injury network criteria, and it has been divided into 3 stages, that is stage 1, 2, and as well as stage 3. Now, if you take the etiologies, right, etiology of the acute kidney injury. So I hope this confusion is clear, right? Okay, so you don't have any problem until now. The definition and as well as acute kidney injury network criteria. So until now, is it everyone clear, or are you having any doubt until here?
No, sir.
All right. Now, let me take up the etiology. So if you take the etiology of the acute kidney injury, we classify this acute kidney injury into pre-renal type of acute kidney injury, intrinsic type of acute kidney injury, or we call it as intrarenal. Then post-renal type of acute kidney injury. Okay, pre-renal, intrinsic renal or intrarenal, and then the post-renal. Now, what exactly is this? Let me tell you. Let me show you that. Okay, you see this image, right? So if the pathology is at the level of the renal perfusion, the kidney, it receives almost 15 to 20% of the cardiac output. And if there is any problem in the renal perfusion, if there is any problem in the blood supply to the kidney, then that will result in what is called pre-renal type of acute kidney injury. If there is any problem within the kidney causing acute kidney injury, that is called intrarenal or intrinsic renal. Whereas, what do you mean by the word post-renal? If the problem is outside the kidney, that is the pathology at the level of ureters, pathology at the level of bladder, pathology at the level of prostate, that will be post-renal type of acute kidney injury. So we classify the acute renal failure into pre-renal, intrarenal, and as well as the post-renal. So pre-renal means where the perfusion to the kidney will be reduced. Intrarenal means where the pathology is within the kidney. Postrenal means where the pathology is outside the kidney. That is the pathology in the ureter, pathology in the bladder, pathology in the prostate in males. Now, let me tell you what are all the etiologies causing pre-renal, what are all the etiologies causing intrarenal, what are all the etiologies causing post-renal. Okay, so you take the etiologies causing the pre-renal first. So what did I tell you in case of pre-renal? Perfusion to the kidney will be reduced. Now, what are the conditions where the perfusion to the kidney will be reduced? So perfusion to the kidney will be reduced whenever there is intravascular volume, right? Intravascular volume depletion. That is one. Number two, due to decreased cardiac output. Number three, due to renal vasoconstriction, there can be decreased renal perfusion. And number four, impaired autoregulation. Okay, right. Now, what are the conditions where there will be decrease in the intravascular volume? Decrease in the intravascular volume can be there whenever there is a hemorrhage, any hemorrhage, or like hemorrhage secondary to trauma, secondary to surgery, secondary to like postpartum hemorrhage, or gastrointestinal losses. Gastrointestinal losses like vomiting, diarrhea can cause decrease in the intravascular volume. Then renal loss, right? What are the causes for renal losses? Like the patient is on diuretic therapy. The patient has developed adrenal insufficiency that can cause decrease in the intravascular volume. Now, can anyone tell me what do you mean by this adrenal insufficiency? Why there will be decrease in the intravascular volume whenever there is adrenal insufficiency? We have finished endocrinology. You should answer this. Yes, any one of you? Why there is decrease in intravascular volume in case of adrenal insufficiency?
Due to loss of aldosterone.
Very good, Basansha. So that is due to decrease or deficiency of aldosterone. Very good, Dilasabam. That is due to loss of sodium. Okay. Right. I think some of you have asked either, I don't know, is it PB or Dilasabam? You have asked me about the hypertension questions. So today I'll be sending you the questions of hypertension on my Telegram channel. Okay. Both hypertension and as well as acute kidney injury, both of them I'll send. Right. And yeah, so these are all the etiologies which will be causing decrease in the intravascular volume. Now, what are the conditions where there will be decrease in the cardiac output? Decrease in the cardiac output can be seen in case of the myocardial infarction. Myocardial infarction causing left ventricular failure. There will be decrease in the cardiac output. Okay. Then, in patients with pulmonary embolism, there can be decrease in the cardiac output and thereby renal perfusion can be reduced. Okay. And you also have this in valvular pathologies. Yeah, please tell me which valvular pathology can lead to left ventricular failure? Yes. Answer this question. Which valvular pathology will cause left ventricular failure or where there will be decrease in cardiac output? Yes, Basansha, Kanchan Gupta. MS, one second. Mitral stenosis will never cause left ventricular failure. Yes, Basansha, you're telling something?
Aortic stenosis.
Right, very good, Basansha and as well as Kanchan Gupta. So it is aortic stenosis, right? And then aortic regurgitation, mitral regurgitation, they will cause left ventricular failure, wherein there can be decrease in the cardiac output. Mitral stenosis, yes, there can be decrease in cardiac output, but in mitral stenosis, you will not have the left ventricular failure in case of mitral stenosis. Right. And Coming to renal vasoconstriction. Now, what are the conditions where there can be renal vasoconstriction? Renal vasoconstriction can be seen in patients with the hypercalcemia. Okay, what is the normal calcium levels? What are the normal calcium levels? Anyone?
9 to 11.
9 to 11 milligrams per deciliter. So what are the endocrine conditions where you will have hypercalcemia? Endocrine conditions where you will have hypercalcemia.
Hyperparathyroidism.
Yes, so you'll have that in case of hyperparathyroidism. What is the most common cause of primary hyperparathyroidism? What is the most common cause of primary hyperparathyroidism?
Solitary nodule of Barker.
Very good, Basansha. So it is the solitary adenoma of parathyroid gland. Okay, right. So renal vasoconstriction, one of the very important etiology is your hypercalcemia, where the normal calcium levels are around 9 to 11 milligrams per deciliter. And even renal vasoconstriction can also occur in the sepsis. Okay. Now, impaired autoregulation. Where do you come across this impaired autoregulation? That is being by your ACE inhibitors will cause impaired autoregulation. Then the NSAIDs, that is steroidal anti-inflammatory drugs. Okay, so these are the one which will cause the impaired autoregulation. So now all these what we have discussed is the pre-renal, where the perfusion to the kidney will be reduced. Then next you need to know what are the intrinsic or the intrarenal pathologies, that is where the pathology is within the kidney. Okay, now let me just give you a basic idea of how these ACE inhibitors and NSAIDs will cause the impairment of the autoregulation. NSAIDs, they are the prostaglandin synthesis inhibitors. Okay, and these prostaglandins, they are required for the afferent arteriolar dilatation. Right, NSAIDs, they are required for afferent arteriolar dilatation. Now, when you give these NSAIDs, the prostaglandin synthesis will get inhibited. Once the prostaglandin synthesis is inhibited, the afferent arteriolar dilatation does not occur. So once the afferent arteriolar dilatation does not occur, what will be the subsequent event? Once the afferent arteriolar dilatation does not occur, renal perfusion will be reduced. Okay, that is what the problem with the NSAIDs. Now you take the ACE inhibitors. What these ACE inhibitors does? Now the pathology or the problem with the ACE inhibitors will be at the level of the efferent arteriole. Now let me show you. Yes, yeah. So you see here, you require what is called as angiotensin 2, which is being formed as a part of RAS mechanism for causing efferent arteriolar vasoconstriction. Right, for efferent arteriolar vasoconstriction, you require angiotensin 2. Once there is efferent arteriolar vasoconstriction, the glomerular pressure increases and renal perfusion will be there. But whenever you are giving these ACE inhibitors, angiotensin 2 is not formed. So vasoconstriction does not occur. So thereby, the increase in the intraglomerular pressure does not occur. So the fluid from the afferent arteriole enters into the glomerulus and immediately it goes into the efferent arteriole and subsequently into the venous system. So thereby what will happen to renal perfusion? Decreases. So NSAIDs, you will have the pathology at the level of afferent arteriole. Whereas your ACE inhibitors, the pathology will be at the level of the efferent arteriole, causing impairment of the autoregulation, resulting in pre-renal type of the acute kidney injury. Right? So I hope everyone has understood the concept of these ACE inhibitors and as well as NSAIDs. Yes. All right. Now, let me take up the discussion of the intrinsic or intrarenal causes for acute kidney injury. So if you take the intrinsic or intrarenal, how do we classify this etiologies? So intrinsic or intrarenal pathologies. The pathology will be at the level of glomerulus. The pathology can be at the level of tubule. The pathology can be at the level of the interstitium, right? And the pathology can be due to glomerulus large vessels. I'll tell you what are those large vessel pathologies. I'll tell you. Okay. Now you take the pathologies at the level of glomerulus, that is within the kidney. That is glomerulonephritis. That is either acute glomerulonephritis or rapidly progressive glomerulonephritis. Okay. And the other pathologies like hemolytic uremic syndrome. These are the glomerular pathologies causing acute kidney injury. Then coming to the tubular pathologies, right, where there can be development of acute tubular necrosis. And this acute tubular necrosis, it could be secondary to exogenous toxins or exogenous pathologies, or it could be endogenous pathologies, acute tubular necrosis. You take the exogenous pathologies. Okay, exogenous pathologies are mainly drugs. What are those drugs? Antibiotics, then radioactive contrast substance, contrast media, and then anti-cancer agents. That is nothing but your chemotherapeutic drugs. Okay. Now, where do we use this contrast media? We use this contrast media during the procedures like coronary angiogram. We use this during CT or MRI that can cause damage to the tubule. Then coming to your antibiotics, you should be very much aware of which group of antibiotics are responsible for the intrinsic type of the acute kidney injury. It is mainly your aminoglycosides. What are these aminoglycosides? These aminoglycosides, they include gentamicin and as well as the streptomycin. Next to the aminoglycosides, you have the chemotherapeutic drugs, that is anti-cancer drugs. These anti-cancer drugs are calcineurin inhibitors, right? Then the another group of drugs are the analgesics, that is analgesic nephropathy, right? Analgesic nephropathy. Okay. Then few more drugs are the antifungal drugs. What are these antifungal drugs? That is amphotericin B. So these are the drugs and antibiotics that will be responsible for acute tubular necrosis resulting in acute kidney injury. Then followed by that, you need to be very much aware of the endogenous toxins, and few more drugs are antibiotics like colistin and as well as the cephaloridin. Okay, that was about your exogenous toxins. And now you need to be very much aware of the endogenous toxins. Okay, endogenous toxins will be released secondary to tumor lysis syndrome. Now, what is this tumor lysis syndrome? For example, an individual is having a malignancy, right? And you have given a chemotherapeutic drug. Now, once you have given a chemotherapeutic drug, what that malignancy does, what will happen? What does that chemotherapeutic drug do? The chemotherapeutic drug will break or will kill or will destroy all the malignant cells. So once all the malignant cells are being destroyed at a time, there will be release of the tumor material into the circulation. And the tumor material, it has to be excreted through the kidney, and the tumor material will cause the urate nephropathy. So whenever the tumor cells are broken down, what is the substance which is being released from the tumor cells? That will be uric acid, right? That will be uric acid. Okay, and this tumor lysis syndrome will develop acute kidney injury that we call it as urate nephropathy. Okay, so this will be the endogenous toxin. Now, and at the same time, you need to be very much aware of what is the most common tumor that will be responsible for your tumor lysis syndrome. The most common tumor will be Burkitt's lymphoma. Right, most common tumor will be Burkitt's lymphoma. Now, the point is, in patients with tumor lysis syndrome, the development of acute kidney injury is mainly because of increase in the uric acid synthesis, okay, or due to increase in the uric acid formation. So what you need to do is you need to give a uricosuric agent, or you need to give a drug which will break the uric acid. So for that, the treatment for tumor lysis syndrome is IV fluids along with furosemide. You need to start IV fluids along with the furosemide. What it does, it will cause the excretion of the uric acid. And we have another drug that is called intravenous rasburicase. What this rasburicase does, this rasburicase, it breaks the uric acid. That is a mechanism of action of the rasburicase. And we have the drugs which will prevent the uric acid synthesis. The drugs which will prevent the uric acid synthesis will be allopurinol, or we have an alternative drug that is febuxostat. Right, alternative drug that is febuxostat. Now it's an acid substance. Okay, so what you need to do, you need to do the alkalinization of the urine. Right, alkalinization of the urine. Okay, so this is about tumor lysis syndrome. So what are we discussing now? We are discussing the exogenous and endogenous agents causing acute tubular necrosis. Exogenous agents are mainly the drugs. Endogenous agents, one of the etiology what we have discussed is the tumor lysis syndrome. So in the tumor lysis syndrome, the most common tumor which will undergo tumor lysis syndrome is Burkitt's lymphoma, right? Followed by that acute lymphocytic leukemia. And in tumor lysis syndrome, there is excessive release of the uric acid from the tumor cells once they are exposed to chemotherapy or radiotherapy. And the uric acid, whenever it is excreting in excess quantity across the renal tubules, it will cause the urate nephropathy. Now, you also need to give the drugs in order to increase the uric acid excretion, for which you need to give IV fluids and as well as the furosemide. And you need to give intravenous rasburicase that will break the uric acid, and IV allopurinol, which will decrease the uric acid synthesis. Alkalinization of the urine has to be done. That is mainly the acidity to get reduced. Okay, so that is about tumor lysis syndrome. Now, few more endogenous causes for few more endogenous causes for the acute tubular necrosis. That is multiple myeloma. So you take in patients with multiple myeloma, what happens? In patients with multiple myeloma, you have abnormal plasma cells forming abnormal immunoglobulins. That is, abnormal antibodies are being formed. These abnormal immunoglobulins, remember, once they cross through the renal tubules, they get accumulated in the renal tubules, causing acute tubular necrosis. Okay, so that is about your multiple myeloma. Then the other endogenous causes for the acute tubular necrosis is the toxic substances. Now, what are those toxic substances? Like the myoglobinuria. Now, where is that condition where there is excessive release of the myoglobin into the circulation? This myoglobin, when it is accumulated in the tubule, that will cause acute tubular necrosis. And the excess amount of myoglobin release that can happen or that will occur in patients with crush syndrome or crush injuries. And the other condition, endogenous toxin, is excess amount of hemoglobin accumulating in the tubule, causing acute tubular necrosis. So what is the condition where there is excessive release of hemoglobin into the circulation? That is in patients with hemolytic anemias. Right? Then the other condition is in patients with gout or gouty arthritis, there can be urate nephropathy. Again, it is the same story. That is because of the uric acid accumulation there. Whereas in case of multiple myeloma, it is abnormal immunoglobulins, which are nothing but the light chains which are being accumulated. So this is about your endogenous toxins. So what are we discussing? We are discussing intrinsic or intrarenal. Glomerular pathologies we have discussed. Tubular pathologies are exogenous and as well as the endogenous toxins. And if you take the pathology at the level of the interstitium, where there can be acute tubulointerstitial disease. So the interstitial pathologies include interstitial nephritis. This interstitial nephritis, it can occur secondary to the NSAIDs and as well as the antibiotics. And we also have some infections which can cause acute tubulointerstitial disease causing intrinsic type of acute kidney injury. And these infections are leptospirosis. What is another name for leptospirosis? Any one of you? Another name for leptospirosis. Very good, Kanchan Gupta. It is called as Weil's disease. So, like, can anyone tell me how is this leptospirosis is being spread? What is the route of spread of this leptospirosis? Yes, Kanchan Gupta. How is this leptospirosis being spread? Right? So that is due to contamination of the food by the cat or rat urine. Right? Contaminated food by cat or rat urine, this leptospira is being spread. Okay? Right. So we have discussed glomerular pathologies, we have discussed tubular pathologies, we have discussed interstitial pathologies causing intrinsic or intrarenal type of acute kidney injury. Then you need to know the large vessel diseases causing the intrinsic or the intrarenal pathologies. That will be your large vessel vasculitis, that is Takayasu arthritis. So in case of Takayasu, the branches of the renal vessels that gets affected. Right, in case of Takayasu, the branches of the renal arteries are being affected. Okay, and that will result in the intrinsic or intrarenal type of acute kidney injury. So what all we have discussed until now? We have discussed pre-renal, we have discussed intrinsic or intrarenal. Now you take the post-renal. Post-renal, what did I tell you? For the development of post-renal type of acute kidney injury, the pathology is outside the kidney. So now what are the post-renal causes? The post-renal causes that includes ureteric calculi, right? Ureteric calculi, then bladder calculi, then benign prostatic hyperplasia in males, then bladder malignancy, right? Then bladder malignancy, then you have the tumors or the masses compressing the ureters or the urethra. That means any adjacent malignancy causing the compression of the ureter, causing the compression of the urethra, that can also result in the post-renal type of the acute kidney injury. And then renal vein thrombosis. Right? So these are the post-renal type of post-renal causes for the acute kidney injury. So in post-renal, what will be the problem? In case of post-renal, the problem will be, yes, you see here, the urinary flow will not be there across the urethra, there will be backflow or the reflux of the urine, causing hydronephrosis, where there will be enlargement of the kidney and then damage to the kidney. So that will be post-renal type of acute kidney injury. So pre-renal, intrinsic renal, and as well as the post-renal. So in case of renal vein thrombosis, the treatment that you need to give is anticoagulant. We give the heparin. And for benign prostatic hyperplasia causing post-renal type of acute kidney injury in males, the treatment that you need to do is TURP, that is transurethral resection of prostate. And in certain conditions, there can be fibrosis of the ureters, that is ureteric fibrosis. Ureteric fibrosis, you come across this in patients with the scleroderma. But this ureteric fibrosis, it should be bilateral ureteric fibrosis. It should be bilateral ureteric fibrosis. Okay. Now let me show you that. So this bilateral ureteric fibrosis, yes. Okay. So whenever there is fibrosis of the ureters, the urinary flow into the bladder, right? Urinary flow into the bladder does not occur. And there will be reflux of the urine causing the hydronephrosis. Okay. So that is about, the etiologies causing acute kidney injury, pre-renal, intrinsic renal, and as well as the post-renal. Now, one point of difference that you need to know is between the pre-renal and as well as the intrinsic renal. Because how can you diagnose the post-renal? Very simple and very easy. Post-renal, all these etiologies, you can diagnose that by ultrasonography. Ureteric stones, bladder malignancies, benign prostatic hyperplasia, ureteric fibrosis, all these can be made out by imaging, either ultrasound or CT or MRI of the abdomen. But the challenging task, right? The challenging task is differences between pre-renal and as well as the intrinsic renal. How will you differentiate? Okay, so how will you differentiate pre-renal and as well as the intrinsic renal type of the acute kidney injury? Now, very important point of difference between pre-renal and as well as intrinsic renal type of acute kidney injury is the fraction excretion of the sodium. Fraction excretion of sodium in pre-renal, it will be less than 1, whereas in intrinsic renal, it is more than 1. How? How do you get this particular value of less than 1 and as well as the more than 1? So for that, you need to know the formula. You need not, it is not required for you to remember the formula, but if you take the explanation with the help of the formula, then you will be able to understand how you will get this particular value of less than 1 and as well as the more than 1. Okay, let me tell you. So fraction excretion of sodium is equal to urinary sodium by the plasma sodium multiplied by plasma creatinine to the urine creatinine multiplied by 100. That is fraction excretion of sodium. Now, okay, creatinine, more or less, it will be of same value in both plasma and urine. We will just keep it aside. Okay, but very important is the urine sodium and as well as the plasma sodium. Now, in case of pre-renal, what is the pathology or what is the problem? The problem in pre-renal is perfusion to the kidney is reduced. So once the perfusion to the kidney is being reduced, now tell me, what will happen to the urinary sodium? Once the perfusion to the kidney is reduced, what will happen to urinary sodium? Urinary sodium reduced. And what will happen to plasma sodium?
Increase.
Plasma sodium will be increased. So which is more now? Denominator is more, or is it like numerator is more?
Denominator.
Denominator is more. So thereby what will be the value? The value will be less than 1. Okay, right. Whereas you take intrinsic renal. One of the very important cause for intrinsic renal is acute tubular necrosis. Once there is acute tubular necrosis, now tell me, will there be reabsorption of the sodium across the tubule?
It will be reduced.
So sodium reabsorption will be reduced. So once the sodium reabsorption is reduced, what will happen to the urinary sodium?
Increase.
Urinary sodium increases. Whereas when the urinary sodium is increased, the plasma sodium will be reduced. So numerator is more. So what will happen to the ratio? Ratio will be, right, more than 1. Okay, ratio will be more than 1. Okay, so this is about how will you make out pre-renal and intrinsic renal. So pre-renal and intrinsic renal, it is made out by a difference that is nothing but your fraction excretion of sodium. So in pre-renal the value is less than 1, whereas in intrinsic renal the value is more than 1. This is a very important point of difference that you need to be very much aware of. Now if you take the urine sodium concentration, so which one will have more urine sodium concentration? Is it pre-renal or intrinsic renal? Intrinsic renal. So in pre-renal it is less than 10, and in intrinsic renal it is more than 20. Okay, and at the same time you need to be very much aware of the urine osmolality also. In pre-renal, what did I tell you? The renal perfusion is reduced. So the urine which is being excreted out is a highly concentrated urine. So the urine osmolality will be more than 500 milliosmoles per kg. Whereas in intrinsic renal, the tubule is injured. Because the tubule is injured, the water reabsorption is also affected. So the urine osmolality will be around 350 in case of intrinsic renal. Then another important point of difference is the renal failure index. It's a calculated value. The value is almost similar to that of fraction excretion of sodium. In pre-renal, the value is less than 1, whereas in intrinsic renal, the value is more than 1. And another very important point of difference is blood urea nitrogen to the serum creatinine ratio. In pre-renal, the value is more than 20. In intrinsic renal, it is less than 10 to 15. So that is blood urea nitrogen to serum creatinine. And next is the urine specific gravity. Which one will have more urine specific gravity? Intrinsic renal or pre-renal? Yes, which one will have more urine specific gravity? The urine specific gravity, yeah, see, specific gravity, it tells you about the concentration of the urine. It tells you about the concentration of the urine. So which is a highly concentrated urine here, Dila Savam? Is it like pre-renal or intrinsic renal? Pre-renal. Very good, Kanchan Gupta. So the urine specific gravity is around 1.020 in pre-renal. It is 1.010 in case of intrinsic renal. Okay, 1.020 in pre-renal, 1.010 in case of intrinsic renal. So that is what is the differences between the intrinsic renal and as well as the pre-renal. How is that you will be able to differentiate? Now just quickly tell me whether all of you have understood this or not. Yes,
Sir,
all the differences.
Sir, what is the difference between PUN and just urea?
Yeah, it is the double. Okay, blood urea nitrogen, it is almost twice the value of just simple urea. Okay, blood urea nitrogen, it is almost twice that of the simple urea. Okay, Vivek Shrestha.
Okay, sir.
Right. Now, yeah, Dila Sabam, right. Dila Sabam is asking, sir, I didn't understand how pre-renal is concentrated. Now, Dila Sabam, tell me, in case of the pre-renal, what will happen to renal perfusion? That will be reduced. So thereby, what will happen to the glomerular filtrate? That will be reduced. And already at the level of renal tubules, there is slight amount of absorption of the fluid. Okay, already reduced glomerular filtrate. Upon that, there is slight or mild absorption at the level of renal tubule. So the urine that is being formed is the concentrated urine. Whereas you take in case of the intrinsic renal. In case of intrinsic renal, for example, let us just assume acute tubular necrosis. The tubule is completely damaged. So thereby, what can happen to water reabsorption? It can get affected. So in intrinsic renal also, you will have decrease in urine output, but the urine which is there, it is concentrated urine, but not equivalent to that of pre-renal. In case of pre-renal, the problem is happening at two levels. Renal perfusion is reduced, and there is also absorption of the fluid at the level of renal tubules. So urine is concentrated. Whereas in intrinsic renal, water reabsorption does not occur adequately, right? And but as such, because of renal failure, you will have a concentrated urine. You will have a concentrated urine, but the concentrated urine in case of intrinsic renal is not similar to that of the concentrated urine in case of the pre-renal. Dila Sabam, did you understand this now, or still you have any doubt? Okay, so these are the differences between the pre-renal and as well as the intrinsic renal. Now, after this, let me take up the clinical features in acute kidney injury. Right, clinical features in the acute kidney injury. So if you take the clinical features, first and foremost, very, very important clinical feature is what? That is decrease in the urine output. That is what is the very important feature that you need to be very much aware of. And the other features are mainly because of increase in the nitrogenous waste substances, right? Because of increase in the nitrogenous waste substances. So the clinical features, we classify that into two. Number one, due to decrease in urine output and fluid overload in the body. Second, you will have the clinical features due to increase in the urea and as well as increase in the serum creatinine. So you take decrease in urine output. How much will be that? The individual will have the oliguria. That is less than 400 ml per 24 hours. Okay. And but one scenario where even though there is acute kidney injury, but urine output is still maintained. Okay. This, I wanted to ask you a question here. Now, can anyone tell me aminoglycosides will cause which endocrine pathology? Let me see who will answer. Aminoglycosides are responsible for which endocrine pathology? Any one of you? Yes, Kanchan Gupta. Aminoglycosides and endocrine pathology. Very good, Kanchan Gupta. Excellent. So, nephrogenic diabetes insipidus. Okay. Now, when aminoglycosides are causing nephrogenic diabetes insipidus, now tell me in diabetes insipidus, how will be the urine output, Kanchan Gupta? In diabetes insipidus, how will be the urine output? in diabetes insipidus, they will have polyuria. They will not have decrease in urine output. In diabetes insipidus, they will have polyuria. So that is the reason why actually in patients with acute kidney injury, there is decrease in urine output. But if acute kidney injury is caused by aminoglycosides, that can cause nephrogenic diabetes insipidus. Here, the urine output is not being compromised. The urine output in case of aminoglycoside induced acute kidney injury, they will have preserved urine output. Right? They will have preserved urine output. Okay. Then next is you will have red or brown urine. In which scenarios you can have red or brown urine? Red urine, you can have that in cases of the hematuria. Right? I said you, right? Hemolytic anemias are also responsible for your acute kidney injury. That is an endogenous toxin. Brown urine, you can come across this in patients with Crush syndrome. In Crush syndrome, there will be rhabdomyolysis, right? Where there will be excessive release of myoglobin into the circulation, accumulating in the tubule, causing acute tubular necrosis. Okay, so red or brown color urine can be there in case of acute kidney injury because of the underlying etiologies causing acute kidney injury. Now, because of the fluid overload, what will be the clinical manifestations? That will be puffy and round face. That is because of the fluid overload. There will be periorbital edema, and this periorbital edema will progress even to the development of the pedal edema. All right. Then next is due to increase in the urea and as well as creatinine. This increased urea will go and get accumulated. Okay, one more important is because of the fluid overload, the individual will also develop hypertension. And secondly to hypertension, there will be hypertensive encephalopathy. Right? Hypertensive encephalopathy. Okay. Right. So that why there is hypertension, that is because of the fluid overload. Right? Or even it could be because of increase in the renin in patients with pre-renal type of acute kidney injury. And because of the fluid overload, there can be even pulmonary edema also. And once there is pulmonary edema, what will be the clinical manifestation? The clinical manifestation will be in the form of dyspnea, acute onset dyspnea, right? Then next is increase in the urea and as well as the creatinine. So once there is increase in the once there is increase in urea and creatinine, the urea and creatinine will go and accumulate in various parts of the body, resulting in uremic manifestations. Okay, so what will be that? Once there is increase in the urea, that increased urea, it can cross the blood-brain barrier. And that increased urea will get accumulated within the brain, causing uremic encephalopathy. And once there is uremic encephalopathy, when you observe the fingers, you will notice the presence of the flapping tremors, which we call it as asterexis. Right, which we call it as asterexis. Okay. Now, can anyone tell me the differential diagnosis for the development of this asterexis? What are the other conditions where you can have this asterexis? Very commonly, you might have come across in your day-to-day routine practice also. Very good contributor. That is in patients with cirrhosis of liver. Okay, that is in hepatic encephalopathy. that is in hepatic encephalopathy. Okay, so in cirrhosis of liver, and even you can come across this flapping tremors or asterixis in case of carbon monoxide poisoning. Right, in carbon monoxide poisoning also you come across this flapping tremors. Okay, right. So that was about your the clinical manifestations because of increase in urea and accumulating that in the brain. And this increased urea will accumulate even within the pericardium, resulting in uremic pericarditis. And because of this uremic pericarditis, the individual will develop chest pain. Right, the individual will develop chest pain. That is because of uremic pericarditis. Right, and the urea will also go and get accumulated within the GIT, causing uremic gastroparesis, where the gastrointestinal motility will be reduced. And once the gastrointestinal motility is reduced, the individual can develop constipation and they also have abdominal pain. Okay, so these are the manifestations because of increase in urea and as well as the creatinine, right? So that was about your clinical manifestations that you come across in patients with the acute kidney injury. Now, so the clinical manifestation, we classified that into two things. One is because of decrease in urine output and fluid overload, and the other one is because of increase in urea and serum creatinine, which are nothing but nitrogenous waste products. Now, you take the diagnosis or investigations. You need to know the biomarkers of the acute kidney injury. The biomarkers of the acute kidney injury, we have some novel biomarkers or the new biomarkers. That includes NGAL, that is neutrophil gelatinase associated or neutrophil gelatinase induced lipocalcin. That is called NGAL. So this NGAL, right, it will be elevated in the blood within 2 hours of acute kidney injury. Right, within 2 hours of acute kidney injury, the NGAL levels will be elevated. Right. Then the other cardiac biomarkers are of the kidney acute kidney injury are KIM1, that is kidney injury molecule 1. Right, this kidney injury molecule 1, it is elevated both in acute and as well as even in case of the chronic renal failure as well. And another important biomarker is cystatin C. Right, that is cystatin C. That is another important biomarker that is being elevated in case of the acute kidney injury. Then what are the other investigations? The other investigations are the serum creatinine. Right, the serum creatinine. So serum creatinine will be definitely
what
elevated.
about IL-18?
Yeah, I will tell you. We have some few more novel biomarkers. The interleukin 18, yes, even that is also being elevated in case of the acute kidney injury. Right, but most common are these three. That is your NGAL, kidney injury molecule 1, and as well as cystatin C. Okay, then serum creatinine levels, they are elevated in acute kidney injury, but that elevation of the serum creatinine, it follows a pattern in case of the contrast nephropathy. In contrast nephropathy, when will the serum creatinine gets elevated is the serum creatinine, it starts getting elevated within 24 to 48 hours, and it reaches the peak value. Right, it reaches the peak value within 3 to 5 days. Right, and when will the serum creatinine will get normalized? That is resolution of the levels of the serum creatinine. Even that is all that occurs within 5 to 7 days. So within 5 to 7 days, the serum creatinine will get back to the normal values. Right, so that is about the serum creatinine story. Now the next is the acute kidney injury can occur secondary to atheroembolism. Right, you are doing a coronary angiogram, there is a lot of thrombus within the coronary artery, And this thrombus from the coronary artery have been embolized into the renal circulation, causing atheroembolic disease, causing acute kidney injury. So in acute kidney injury, secondary to atheroembolism, what is the very important manifestation is complete blood picture, right? CBP, okay, complete blood picture. It will show you the presence of the eosinophilia. Okay, complete blood picture, if it is showing eosinophilia in a case of acute kidney injury, that indicates the atheroembolic disease. Then the urine examination will show you the presence of cast. Then the electrolyte abnormalities can be there. What will be that? Potassium. Potassium, it has to be excreted through the kidney. And when the kidney is damaged, potassium is not excreted, and that will result in the hyperkalemia. And not only that, even the phosphate, which has to be excreted through the kidney, that will be also elevated. Then the sodium levels are reduced. Why? That is because of fluid overload causing dilution effect. There will be dilutional hyponatremia. Right? There will be dilutional hyponatremia. And what will happen to the serum calcium levels? Serum calcium levels, they are reduced. Okay. So there will be hypocalcemia. Why there is hypocalcemia? Because the calcium, it combines with phosphate. The phosphate is elevated, right? So why phosphate is elevated? Because once there is acute kidney injury, the phosphate is not excreted out, the phosphate levels are elevated. So once the phosphate levels are elevated, that increased phosphate will combine with calcium, resulting in the calcium phosphate. So thereby what will happen to the calcium levels? That will be reduced. So there will be hypocalcemia, right? Then fractional excretion of sodium already we have discussed. Urinary sodium also we have discussed. Then you need to do ultrasound abdomen or the CT of the abdomen. So ultrasound abdomen or CT of the abdomen, it is very much useful in diagnosing the post-renal causes of the acute kidney injury, right? And because there is like hyperkalemia, what will the ECG show? ECG shows the presence of tall T waves, right? ECG shows the presence of tall T waves. Now, next important is, now can anyone tell me what about this sodium bicarbonate? At which level the sodium bicarbonate or bicarbonate is reabsorbed? Any one of you? At which level the bicarbonate is reabsorbed? No. It is not at the level of loop of Henle. Bicarbonate is reabsorbed at the level of PCT, proximal convoluted tubule. Now tell me, bicarbonate, is it an alkaline substance or is it an acidic substance? Is it an alkaline or is it an acidic substance? Bicarbonate.
Alkaline.
Alkaline. So now, once the tubule is damaged, the bicarbonate is not absorbed. When bicarbonate is not absorbed, the alkalinity is out. So thereby what will happen to the pH in the body? Thereby what will happen to the pH in the body?
Increase.
No. The pH in the body decreases. Okay. So there will be metabolic acidosis. Yes, Vasansha, did you understand that?
Yes, sir. Yes, sir.
Right? So there will be metabolic acidosis. So when you do an ABG will show you that there is metabolic acidosis. Okay. Right. Then what are the other markers of the acute kidney injury? Right. So we have discussed kidney injury molecule 1, KIM1. Then we have discussed the cystatin C. Then we have discussed neutrophil gelatinase associated lipocalcin or induced lipocalcin. Whereas the other biomarkers of the acute kidney injury are, remember, it is not acid phosphatase as a marker of acute kidney injury. It is the alkaline phosphatase, which is the marker of the acute kidney injury. That will be elevated. Then next is alanine aminopeptidase. that is also elevated. Then glutamyl transpeptidase, that is also elevated. Alpha 1 microglobulin, that is also elevated. Beta 2 microglobulin, that is also elevated. So these are all the kidney biomarkers of the acute kidney injury. These are all the biomarkers of the acute kidney injury. Coming to the treatment. Okay, so I hope everyone is clear until now, no problem. Yes, any doubt until here? Up to the investigations. All right, now we'll move on to the treatment of the acute kidney injury. So treatment, you need to treat the underlying cause, whatever might be the underlying cause. Like for example, tumor lysis syndrome is the underlying etiology. Then you need to give IV fluids plus furosemide. Along with that, drug of choice will be intravenous rasburicase, which will break the uric acid. And the other alternative drugs will be allopurinol. Okay. Then next to the tumor lysis syndrome, like myoglobinuria, that can be seen in rhabdomyolysis. So patients with rhabdomyolysis, they have to undergo forced alkaline diuresis. Right, forced alkaline diuresis. Then if there is volume overload in the individual, right, if there is volume overload in the individual, how do you treat? So first and foremost, salt and fluid restriction, right, that is one important thing. Okay, salt and fluid restriction. You need to give diuretics like furosemide. In which type of or in which etiology of acute kidney injury you should not give furosemide? In which etiology of acute kidney injury you should not give furosemide? If you give furosemide, the acute kidney injury will further get precipitated. Anyone? Please think and tell me. Yes? Very good, Dilasa Bam. Right? That is in case of pre-renal. Right? In case of pre-renal, you should not give the furosemide because the cardiac output or in renal perfusion is already reduced. And upon that, if you give furosemide, the fluid volume further reduces and the renal failure will further get precipitated. Okay, right. So volume overload you need to treat with salt and fluid restriction and then diuretics, except in case of pre-renal. Okay, and then you also need to do ultrafiltration. Right, you also need to do the ultrafiltration. Right, next is the hyponatremia. So if there is hyponatremia, right, if there is see why there is hyponatremia, dilutional hyponatremia. If the individual is asymptomatic hyponatremia, then just only fluid restriction will be sufficient. But secondary to hyponatremia, if the individual is symptomatic, then you need to give 3% sodium chloride. Then you need to give 3% sodium chloride. What do you mean by symptomatic hyponatremia? For suppose if the individual is developing seizures secondary to hyponatremia, then you need to give 3% sodium chloride. Then these patients, they have hyperkalemia. Okay, so what will be the drug of choice for hyperkalemia? That is calcium gluconate. This calcium gluconate actually will not decrease the potassium levels. The only thing, calcium gluconate will prevent the development of the cardiac arrhythmias secondary to hyperkalemia. Okay, it prevent, or it will see that the cardiac membrane is not being sensitized. And the another treatment options for hyperkalemia will be, you need to give loop diuretics. This loop diuretics will cause the loss of the potassium. And the other drugs that you need to give is, you need to give salbutamol nebulization. Right, salbutamol nebulization. Okay, that will shift the extracellular extracellular potassium to the intracellular compartment. And even insulin plus dextrose, even this one also will shift the extracellular potassium to the intracellular compartment. And finally, we have potassium binding resin. Right? What is this potassium binding resin? It will bind the potassium and it will excrete the potassium through the feces. An example of this potassium binding resin will be sodium polystyrene sulfonate. Right, sodium polystyrene sulfonate. Okay, so and in refractory cases of hyperkalemia, right, in refractory cases of hyperkalemia, you need to do hemodialysis. That means if the patient is not responding to the medical management, then you need to do the hemodialysis. And I said you that these patients, they develop metabolic acidosis. That is because of loss of bicarbonate. Now, how will you treat this metabolic acidosis? You need to give intravenous sodium bicarbonate. And when will you give this intravenous sodium bicarbonate? If the pH is less than 7.2, then you need to give intravenous sodium bicarbonate. And I said you, these patients, they have the hyperphosphatemia because phosphate is not excreted out. So how will you treat this hyperphosphatemia? You need to give phosphate binding agents. And what are the examples of these phosphate binding agents? That includes sevelamer hydrochloride or aluminium hydroxide. These are the treatment options for hyperphosphatemia. And I said you that these patients, they develop hypocalcemia. So how will you treat hypocalcemia? The treatment of hypocalcemia is, you need to give calcium carbonate, right? Calcium carbonate. Okay, so this is about the treatment of the acute kidney injury. And at the same time, you need to know the indication of dialysis. Right, indications of hemodialysis in the acute kidney injury. Right, indications of hemodialysis. Okay, before the hemodialysis story, let me tell you, how do you treat hypertension? Because these patients, they develop hypertensive encephalopathy because of the fluid overload. So for that, you need to give intravenous labetalol, which is both alpha plus beta blocker. Okay, now tell me which endocrine pathology we give this labetalol. Yes, in which endocrine pathology we used labetalol?
Pheochromocytoma.
Very good, Bus and Shine. Pheochromocytoma, we give labetalol. In pregnancy hypertension, we give labetalol. Okay, very good, Kanchan Gupta. And next important thing you need to know now is the indications of dialysis in case of acute kidney injury. Right, indications of dialysis in acute kidney injury. So the mnemonic that you need to know is, there are many indications. Just remember this mnemonic, that is have P. What do you mean by that word have P? The word H, it stands for hyperkalemia. What type of hyperkalemia? That is refractory hyperkalemia. That means not responding to medical management. A stands for acidosis, that is refractory acidosis, not responding to medical management. Volume overload, that too refractory volume overload, right? Not responding to medical management. Then the word E stands for elevated blood urea nitrogen, and how much that should be? More than 35 millimoles, right? And the word P stands for pericarditis, right? The word P stands for pericarditis. And finally, E stands for encephalopathy, right? And then 5 minutes. Then edema, and that particular edema will be pulmonary edema. So these are the indications for the hemodialysis in patients with acute kidney injury, right? So you can just remember this mnemonic, that is half P. So this finishes the topic of the acute kidney injury. So if you have any doubts, you can ask me, I will answer right away. And at the same time, I am also sending you this PDF on my Telegram channel. You can download that from my Telegram channel. That is topic of acute kidney injury. And I'll be sending you the questions of acute kidney injury today. Please read the topic and solve the questions. And tomorrow we will try to take up the questions if you have any doubts as well. Okay. And some of you were asking me about the staging in KDIGO you don't have. Staging is there in acute kidney injury network criteria. In KDIGO you have only definition. All right. So, okay. So if you have any further doubts, you can just text me on my Telegram or Instagram. Definitely I'll take your questions, and download the PDF from my Telegram channel, wherein that will be very much useful for you for revision part. Okay. Thank you very much. See you tomorrow again at 9. So tomorrow class also will be at 9 a.m. sharp, wherein we will be discussing the chronic renal failure or chronic kidney injury.